Well, good morning, everyone, and thank you so much for joining us for the CTSC Spotlight Series. We are joined today with our Bird Services Part 2. And we are discussing propensity score matching and observational clinical research. So we are excited to welcome our presenters. The Spotlight Series, just as a brief overview, is really to help promote the services and resources available through the CTSC of Northern Ohio. And again, for a variety of services, resources and services, funding opportunities. We've got community engagement, workforce development, health informatics, and a lot of you are repeat offenders, I can see on the registration. So thank you for coming and continuing to engage with the CTSC. If there are ideas or any other future topics that you would like to see in terms of our Spotlight series or promoting different services, something that maybe you have seen as helpful, please reach out, let us know. We love to continue these on and see the engagement as it moves forward. So today we again are continuing on. This is kind of part 2. If you missed the last session, the last Spotlight series in June, that was kind of Clinical Design 101 with our bird services, and Jennifer Murphy presented last time as well. So she's back and Jared is back. We are happy to have them both from our collaborator University Hospitals. And I'm going to let them introduce themselves and give a little bit of information about who they are and what they do. And then Jared's going to kick off the conversation. So thank you so much for joining us. Welcome, Jared and Jennifer.
Thanks. Jennifer, do you want to introduce yourself first?
Sure. Hi, everyone. I'm Jennifer Murphy. I am a biostatistician data scientist in the Clinical Research Center at University Hospitals. I also help out at the CTSC as a statistician, working with them and working on projects and all different fields. And I'm really excited to be here. So go ahead, Jared.
Oh, thank you. Yep. So my name is Jared. I too work primarily for University Hospitals and help out with the CTSC with statistical support. I've been with UH for, gosh, a little over 5 years, I believe, at this point. So, yep, have really enjoyed getting involved in lots of different types of studies, different therapeutic areas. I like the challenge. Yeah, thank you. All right, let me see. Let me start sharing here. Right. Can everyone see? Does that screen show up? Okay, perfect. Awesome.
Yep, looks
All right.
great.
Yep. Thank you. Thank you. All right. So as mentioned previously, Jennifer touched on some really important things that that we're going to kind of build on since that last session. So she covered some elements of like a good clinical study design and highlighted some things that, why that's important, how it ensures that we can produce reliable, valid results, how a good study design can also really assist with minimizing bias and support evidence-based decision-making. She also highlighted some common pitfalls that we should be aware of when we're designing studies, things that could present problems, whether that's in confounding or if we're dealing with small sample sizes and things of that nature. She also introduced the PICO framework as really good tool to kind of operationalize research questions. And it also helps kind of really outline inclusion and exclusion criteria, which is very important and sometimes is often overlooked. So we're going to kind of piggyback off of that as a kind of a foundation to kind of introduce propensity score matching. And then we're going to look at maybe some ways to demonstrate how we can use some different techniques to identify confounders. We'll briefly review matching methods, and we're just going to highlight a few, not go into detail. We'll outline some of the strengths and limitations of using propensity score matching, and then we'll review an example. So we won't go into like a live, essentially demonstration as Jennifer kind of did with Trinetics platform the last time. So the intent here is just to kind of have a high level overview. We're not going to get into some of the more statistical details as much as possible. If you are interested in knowing more or just want to have conversations, definitely reach out to us afterwards. We can talk through that, and hopefully answer any questions you have. So in short, this is really just, we want to highlight this is a service that we can offer any clinical researcher. So so again, just a really high level kind of introduction here. So one of the objectives of clinical research typically is that we want to generate evidence to support clinical decision making. And the way that we want to achieve this objective is that we use a variety of study designs and analytical methods to compare the effects of whether it's different treatments or interventions on the course of a disease. So regardless of the type of study design, whether it's a randomized trial, perhaps a cohort or case control, our aim is always the same, which is we want to produce accurate and reliable findings. So in a randomized study, participants are typically randomly assigned to either to receive treatment or not, essentially a placebo or control group. So the probability of receiving treatment is 0.5, and the probability of not receiving treatment is also 0.5. So the probability of receiving, whether it's the investigational treatment or not receiving treatment, is the same. So we would say that a participant's actual exposure or treatment status is random. So this results in treatment groups that are balanced on both measured and unmeasured baseline confounders. So one of the biggest challenges we have in observational designs and studies is that this probability of whether it's being exposed or receiving a treatment or not is not random. So and as a result, this produces treatment groups or comparison groups that are not similar on baseline factors. That could be disease severity, comorbidities, it could be demographics and things of that nature. And these baseline factors that they may determine or have an effect on the outcome. So any differences or associations between whether we're looking at intervention or a treatment or exposure, any of those differences between the groups become less clear. It introduces the idea that any differences we see in the outcome of interest might be a result of something else, essentially. So baseline factors, as we mentioned, maybe it could be age, sex, race, comorbidities that are different between groups and also known to be associated with the outcome. We consider those as confounding variables. This is really important that we're highlighting here for propensity score matching, as we'll get into. So as many of you probably already know, confounding variable, it really hides that relationship between whatever our intervention or exposure treatment, and I'm kind of using those interchangeably here, and mask that association with the outcome. And so as a result, we end up either potentially underestimating or even overestimating what that relationship actually is. So confounding bias threatens our ability to produce, valid, results. So in observational studies, this is probably one of the more important and challenging kind of methodological challenges that we need to control for this bias, because it's due to the lack of our ability to randomly assign treatment or exposure. So there are different approaches, but for today, we're going to focus on propensity score matching as a way to, as a bias control tool that essentially mimics random assignment in the absence of randomization. So just to set the stage, propensity score matching. So a propensity score is a conditional probability of being exposed or receiving treatment given a set of covariates. And again, that's typically measured baseline confounders. So a propensity score then is calculated independent of a participant's actual treatment or exposure status. So that way, the probability of being exposed or receiving treatment is the same as the probability of not being exposed or essentially not receiving treatment. So that both treated and exposed participants are then matched to controls or unexposed individuals with the same or similar propensity score. So this essentially sets the stage for us that when we condition on the propensity score, it's a way for us to say that each participant has the same chance of receiving the treatment or being exposed, which we would say would be random. Now, the difference between this and what randomization or random assignment in like a randomized study would do is that this does not control for unmeasured confounding, which is why when you look at like a hierarchy of evidence, even propensity score matched studies are still lower on that evidence hierarchy. So probably I'll say one of the most important things that we need to consider is the selection of covariates. And just a little parenthesis here, this, as I'll highlight even later, this does not replace or supplement a poorly designed study. So this goes back to, again, some of the design elements that Jennifer had highlighted in the last session, identifying the population, clearly defining inclusion and exclusion criteria. So this tool is not meant to essentially correct for not doing or overlooking some of those really kind of foundational steps in operationalizing your research questions. So to estimate the propensity score, we need to select covariates that are predictive of both the treatment assignment and the outcome, which essentially would be the definition of an actual confounder. So a little warning here is that if we fail to include a variable or in this estimation model, if you will, or if we just kind of take, everything that, a large, set of covariates, and we just kind of throw it in the model and just see what happens, it still presents an opportunity for us to either over or underestimate the true relationship between, our intervention or treatment and the outcome. So this is typically a step where any baseline covariate that we want to use in estimating propensity score is something that typically comes before we get to this point. So it's based on whether it's clinical knowledge or just from other published research on in similar populations that have identified specifically known confounders. So the variables that we want to exclude are anything that could be a result of the intervention or treatment. So we really want to focus on pre-treatment, variables that, again, are both associated with the treatment and essentially our outcome of interest. So the best way to visualize this, at least personally, is to use a tool. I'm sure many of you have probably seen are these directed acyclic graphs. And so we'll actually look at kind of a conceptual view. So you'll see on the left side here that, whether we're looking at a treatment or an intervention or an exposure, whatever these baseline covariates are, again, that could be age, sex, race, lipids, BMI, or some other factors that we that are known. You'll see that the direction of these arrows indicate essentially a relationship. So if they're just take age, for example, if baseline age was associated with, some treatment that we're interested in, this direction is indicating that there is a, we'll say, statistical relationship. And similarly, on the right side, that age is also associated with, an outcome of interest. So if for some reason age was in this population that we're interested in studying was not, known to be associated with either, then by definition, we may consider not including that in our propensity score estimation model, because it doesn't really fit the definition of being a true confounder. So we really only want to include variables and condition on variables that are kind of predictive in a sense of both the treatment and the outcome. So the most common methods, propensity score matching methods, these are just a few. Some of this will depend on, for example, if you're using Trinetics platform to kind of design a study and derive your sample, or if the statistician or someone you're working with is programming in SAS or R, these are some of the methods, more common methods. And one you probably heard of greedy nearest neighbor. That's probably one of the more popular ones. There's optimal matching, and there's also matching with replacement. So most of these methods, where they vary generically is that in how they're selecting patients, or I should just say your treatment and control groups, if you will. So there are lots of other techniques essentially nested within these methods that we're not going to cover today, but there is, I would say, limited research right now on which is the best, essentially, method, if you want to call it the best method to use in different situations. To my knowledge, to date, most of these methods will produce very similar results. Where you're going to see differences are when you are using a smaller sample size to you want to implement propensity score matching and you have a small sample size. You might see some differences with the sample that's derived from these, or if it's the sample that however you generated the data for the sample, it's just not an optimal or good set of a good set of population to derive a comparison group, ideally. So other than that, there is not a lot of guidance on, oh, you should use this method as opposed to this method in this scenario. I think there's still kind of research that's looking at some of those things and identifying, but again, we're not going to go into those details. So once we have the set of covariates and we use that to condition, and generate this propensity score, then we can match based on this propensity score. one of the things that we want to do after we've matched is that we want to check this balance. And now there are a lot of statistical ways to do this, but we're not going to get into those. So, so one of the methods that we can use to check how well or how balanced our groups are that we've just derived is to compare baseline characteristics before and after matching. And we'll actually look at an example here shortly. So one thing to keep in mind is that the purpose of using propensity scores in observational studies is to create balance in the distribution of baseline confounders. So strengths, I think we've probably already mentioned some of these. So balance on baseline covariates improves the validity of our findings. So yeah, and again, it doesn't correct for a poorly designed study. Another potential benefit of using this method to derive our sample is that propensity score match participants may be more representative, sample of like a real world participants than potentially those in a randomized, trial setting. One of the other nice things about using this method is that we don't need to necessarily rely on these large covariate adjusted models to estimate the effects of receiving treatment or being exposed. So typically in most studies, we would always present, as most people are probably familiar with, an unadjusted and an adjusted models. And one reason for looking at the adjusted models is it could be for precision, or it could also be for, looking at how some of these other third variables, if you want to call them that, potential confounders or actual confounders, if they change that association of the treatment or exposure and the outcome relationship. So propensity score matching, because we're conditioning on those baseline covariates, we're generating a sample that is more likely, let me say this a different way, that presents a way for us to kind of get rid of the noise of confounding, at least measured confounding. So the differences we see can be attributed to our treatment or intervention that we're most interested in, and not necessarily that it would be a result of, say, difference in age or a difference in the proportion of male and female sex between the groups and things of that nature. So there's a few limitations and some just a few other things to consider. Missing data creates a problem for propensity score matching. So just as probably most, not all, but there, softwares and statistical techniques, typically will do what's called complete case analysis. So that follows in line when you're looking at generating a propensity score. So if any of those potential confounders, age, sex, race, anything like that, if any of those, that data is missing, then the propensity score will also be missing. So in effect, it actually may introduce selection bias, depending on how we approach it. There are some, various missing data methods and approaches that could be implemented to help minimize or eliminate that possibility. But it's something that's really important to keep in mind, especially if we're looking at pre-existing data, whether it's coming from Trinetics or some other data repository, retrospective data that was collected maybe for a different purpose. Clinical data is typically messy, and it's not uniform, and missingness is typically an issue that we typically always have to deal with. So keep in mind that if there are no imputation methods or other ways to deal with missing data prior to propensity matching, then by simply generating a propensity score in those scenarios may actually introduce a selection bias, then essentially create some other we'll say issues that we would need to address as we go out, through the analysis phase. So another thing to consider is that in small sample sizes, propensity score matching might increase the probability of creating a type 2 error. And this was really related to how the match works. So if for example, if you have, you start off with a total sample size of 100 participants, and we'll say 40 of them have been exposed or received treatment, and you want to propensity score match from this sample of existing 60. So best case is that you'll find in a one-to-one match that's 40 out of those 60 will match, which would probably be unlikely. So in effect, we're actually reducing the sample size. So anytime we're reducing that sample size, we are at risk of creating this type 2 error. So one of the other things with a small sample size that with the same example is that there is a high possibility that there's going to be incomplete or inexact matching. It's possible that you're not going to have a participant that has a similar enough propensity score if the sample that it's drawing from isn't large enough. So again, that may result in a sample that is significantly less than what you started with. So in those scenarios, it may not be ideal to implement propensity score matching, but typically that's something that we would look at kind of on a case by case. So as I've already stated, propensity matching is not a supplement for a poorly designed study. Say it a few times just because how important it is. The following that's kind of outlined inclusion and exclusion criteria is so important. Otherwise, it would be very difficult to match on a sample when the I guess some of the kind of baseline factors are irrelevant in general. So this last point, confounding bias, that is not dependent on sample size. So just because there's a study, and as many of you probably know with Trinetics, we can generate really large sample sizes when we use that platform for studies. So just because we have a large sample size, it doesn't mean that confounding bias, for example, goes away. Doesn't mean it doesn't exist or it's kind of hidden. So whether you have a sample size of 50 or 5 million, confounding bias is still an issue. And it's important that that's taken into consideration as we design studies going forward. So I guess I can stop for 1 second because I want to go into an example of a study that had how it was implemented and so what some of these things look like in practice. So before I do, is there any questions, anything that I need to go back and maybe highlight or discuss?
Feel free to unmute or
Yeah.
drop your questions in the chat.
Okay. I'll assume no questions for right now. All right. So one example I want to look at is this cohort study. So the objective of this study was to investigate temporal changes in inflammation and gut integrity and better understand sex-specific differences in endothelial function among COVID-19 survivors with long COVID. And it looks like I see the D was cut off there. Sorry about that. So the study sample included adults who were age 18 or older, had no history of coronary artery disease or cardiovascular disease between January of 2020 and 2021. They had no history of acute respiratory illness since December of 2019, and were able to provide informed consent. The COVID positive patients were COVID survivors with a prior documented infection, and COVID negative participants had either no documented history of infection and were antibody negative. So COVID survivors that had 2 or more COVID-related symptoms that occurred at least 1 month following COVID infection and lasting more than 3 months were defined as having long COVID. So some of the confounding variables that were identified prior to matching in this study are listed here. So this study identified age, sex, race, BMI, lipids, and hypertension and diabetes, and current smoking status. So these were all variables that were used in estimating the propensity score for the study. So COVID negative participants in this example were matched, 1-to-1 propensity score matched on these baseline confounders to COVID survivors. The method used here was the greedy nearest neighbor without replacement. And these next 2 sentences were just kind of in there for reference. So there are different parameters that you can use, or if you want to say tweak, that ways that you can check the covariate balance and look at how well your propensity score, or if you want to say how good your propensity score actually was at deriving your sample. We're not going to go into those here. We're going to actually look at some kind of more practical ways that we can actually identify how good essentially we were at coming up with a match sample. So this is just a screenshot of before propensity score matching on these variables. You can see that, just looking at age, for example, that, the median age in the COVID positive group is around 48 compared to 35 in the COVID negative group. You can see over here on the right, that the differences between groups, it looks like before propensity score matching, they are different. The proportion of sex is female sex was different between the 2 groups. Whether or not the proportion of current smokers in the groups as the same with comorbidities with diabetes, hypertension, and it looks like so BMI, LDL, cholesterol, okay, not so much with non-HDL and triglycerides. So based on after matching, so one way to, again, is to check how well those baseline covariates were in matching after matching. And one more thing before I go to the next slide here, I want to notice here is that look at the sample sizes currently for each group. We have 162 for the COVID positive group, and then approximately 217 in the COVID negative group. So after matching, based on that method, you see how much the sample size changed and decreased. So now we're at 1-to-1 match. So we have 89 in both groups. And one indicator that the match, as we'll, for lack of a better word, say it was a good match, is that when you look at to establish if there are any differences in those kind of baseline covariates, we can see that in every covariate listed here, that there's not enough evidence to suggest there's any differences between these two groups with respect to these covariates. So without going into detail with some of these more elaborate statistical approaches, that's something that we would obviously look at on the back end, but visually, even if we're reviewing or looking at different research articles, assuming they're publishing both their before and after propensity score match sample, results, you can just look to see potentially if how they derive that sample, how good they were at identifying prior to doing any analyses, how good they were at identifying covariates to match on. So sorry, the screen is cut off here. So just a basic summary again, that propensity score matching, it's a way for us to control confounding bias, a way that we can mimic random assignment in the absence of randomization. Again, it's not a supplement for a poorly designed study, and the importance of balancing on those baseline covariates really does improve the validity of our findings. So whether you're designing a cohort study, a case control study, anything that is looking at whether it's prospective or retrospective, data, this method is something that you could consider, whether it's for the analysis, for your analysis population, or even I would suggest it could also be used even as a way of a sensitivity analysis. So perhaps you wanted to use this approach to show that even in the presence of some of these differences, that how it might affect differences that we see in the outcome. I've also have seen it used in that respect. So again, this is just one tool, and I think that's probably becoming more and more popular, especially as you see things like real world evidence, terminology being floating around quite frequently now. I would also suggest that this method could potentially be used even in randomized trials. Randomization doesn't always work how we think. Using this approach could also be used in that scenario. I've also seen in early phase clinical trials how propensity score matching is now being considered in their designs. So for example, if there's only enough funding in a trial to say fund 100 treated participants, and recruitment is already difficult in a population, that I've seen where to improve enrollment and recruitment, that part of the strategy is that their control group or comparison group might include a historical propensity matched, group of individuals. There's not a lot of that I'm aware of FDA guidance in those scenarios, but it seems to be more and more widely accepted as a way to generate a control population, even in randomized trials. So anyways, with that said, this again is just a tool to be used in designing your studies, and something that, again, we wanted to highlight, that we can assist when you get to that point, deriving that sample and putting together, even driving the confounding variables and assisting with that. So I think I'll leave it at that for now. And open it up if there's any questions, or Jennifer, if there's anything else you want to add or contribute, please feel free.
There's a question in the chat, Jared.
I don't see the chat on my
I can
side.
read it. It says,
Yep.
if the unit of observation isn't patients, but encounters or treatments, hospital admissions, etc., and some patients have multiple encounters, are there special considerations you need to account for the propensity score model, or is it better to just limit the sample to one encounter per patient?
So if I understand the question, ideally, considering like something that's longitudinal, repeated measures, is that just to make sure I understand?
Sam, if you want to
yeah,
go
please.
off mute.
Yeah, so what happens? So let's say you have hospital admissions, right? And some hospital admissions get music therapy, which is my dissertation, and some hospital admissions don't. Every hospital admission is a unique observation, right? And some patient could have gotten music therapy and some, but not others. You know, if you're using a propensity score model and you're plugging hospital admissions into that model, are there adjustments you can make when you have repeat patients, when you're looking at things that just happened in the hospital admission, or what I ended up doing was just picking the first hospital admission among unique patients.
Yeah, I got to think about that one. Yeah, I mean, ideally, if it's as you did the first one, we could call the baseline. If anything that any covariate in this scenario that would occur before or up to that time point, I think is the I'm trying to think of from your perspective. Yeah, I got to think about that. There potentially is a way that you don't have to just limit it, but I would need to I need to think about that some more. Yep. So something that has repeated observations, repeated measures, even if they're inconsistent among participants, establishing what the baseline is and using that as a way to identify those covariates that are affected prior to or up to baseline, they could still be effective. So yeah, I got to think about that some more. Yeah. Thanks for making my head itch a little bit.
There's a second one. If planning for multiple secondary outcomes, should covariate set relate to all outcomes or only the primary?
Oh man, that's a good one. Very good question. So typically you really want it. All right, before I answer, can you read that one more time to make sure? Because I heard the primary and secondary outcome. I don't want to respond too quickly.
Yeah. If planning for multiple secondary outcomes, should covariate set relate to all outcomes or only the primary?
So as relates to propensity score, we typically don't consider the outcome as we're deriving it, only if we're trying to determine if something is a confounding variable. So is it possible that the confounding variable isn't confounding for a secondary? Yes, that's definitely possible. Typically, if it's we always want to focus on the primary outcome first. As it relates to the secondary, if those covariates are not necessarily confounders, I would say it would be a good opportunity where we could introduce additional, comparisons, if you want to call it, as a way of the sensitivity analysis to look at, what other propensity matched models, how they might change that estimation. But the complication is that you still want to be able to use the same sample, so that you used for your primary outcome. Yeah, I think we would have to look at before and after, before propensity and after propensity score matching. And if something is not related in those secondary outcomes, we would have to look at ways to see how that would, that's a good question. It's possible that in your secondary outcomes, it could, bias the result in some way, whether it's over or underestimating that, that relationship. Man, that's good. Thank you for that. That's, I'm going to think about that one some more. I don't think I've even read, even recently, anyone that has discussed that impact, because you're right. That would actually, that definitely creates a situation where you're, conditioning on something that you may not necessarily need to. So, yeah, very good question.
We're making you think on your toes
I
today.
mean, no, it's good, and that one is I haven't actually considered that one, but that's really good. Yeah, thank you.
And Mesh, you have a question?
Yeah.
Sorry if I mispronounced.
Hey, thank you so much for this interesting discussion. When you were talking about kind of some of the algorithms for propensity scoring, when you showed your slide, when you were talking about, like, here are the a priori confounders identified, right? Age and sex and race, BMI, lipids, etc. Are those weighed? Like, how because they're you just mentioned that you try not to think about the outcome when you're doing the propensity scoring, but the contribution of age versus the contribution of lipids might be different in the risk of respiratory distress in this population. So how do you weigh the various covariates in that analysis?
So, I mean, the way the propensity score works is that it's theoretically how it's trying to use the information, not necessarily in a weighted sense. There, I mean, we could look at inverse probability of treatment weighting and things of that nature. It's not necessarily weighting that important as you're describing it. It's looking at, I think, more in a generic sense of, if we're trying to compare, for lack of an argument, two groups, and either the distribution of, like you said, maybe age or some other factor is different between the groups, and let's say so is some other variable is also different between the groups. That is it possible, if we don't weight one of those covariates that we know have a higher or greater influence on the outcome? I think the idea is that we're trying to make one individual, one group, and the other group to be as close as possible, whether it's age, whatever these other factors are. So in essence, whether or not one variable has more of an influence is being accounted for, and how it's matching the between the individuals in the two groups. So in essence, it would not really have an effect based on that, assuming it was a good match. I think I could envision where if it's not a good match, that those variables that have a greater influence will affect, have a greater effect on some of those differences we see later. How much, I don't know, actually. I think that would go back to, if even after propensity matching, if the distribution in those baseline covariates are still different, then I would suggest it's not a good, this method I wouldn't use, essentially. If say we used matching with replacement, and we had a large sample, and the differences between the group, there was still a large difference in these factors that are really important, I would probably argue that propensity score matching probably isn't a good tool to use in this scenario. And it might be more efficient to then just use our traditional approaches and covariate adjusted models to describe that relationship between, whatever we're interested in the outcome. There probably is, I'm trying to think, there is ways to weight things in some of these models, like creating different weights and then implementing those weights in the propensity score. I'm trying to think of a scenario where I've used it, but yeah, you raise a really excellent question, because if something is known to have a greater influence, and if propensity score matching, has its limitations, it's possible. I would say that that weight, without predefining a weight, it would still be distributed the same in those variables that it's matching on, if that makes sense. So if it exists before matching, it would still exist in the same way after matching, assuming the match wasn't very good, would be my thought. Yeah.
Cool, thank you.
Jennifer, is there anything you would like to add as we wrap up the conversation here?
No, that was absolutely fantastic, Jared. Thank you so much.
Great. Well, thank you, Jared. We appreciate your time, and just with a couple final announcements here. Thank you all again for your engagement. For those continuing on, if you happen to read or in your clinical observational research, we're hosting on Thursday, July 10th, a Red Cap overview with Sherry Hemphill here at the CTSC of Northern Ohio. If you cannot attend, of course, register. These sessions are often recorded and then sent out to those who have registered after the session. Additionally, we also offer scientific writing open office hours every Thursday at 11 a.m. There's no registration required for those, so you can visit our CTSC calendar on our website to find the information on how to join there. And lastly, just thank you to Jared and Jennifer for presenting these last two Spotlight series on our bird and clinical design and research. Next month, our Spotlight series will be discussing competitive proposals through Team Science. You can register for that and other future sessions with that QR code. If you have a bird or any other type of service request through the CTSC, you can submit a Spark request. We do have a research navigator to help kind of navigate through that. If you've never done a Spark request before, we have somebody on site to help you. And of course, if you are a member, it's free to join. If you're not, but that is the best way to stay up to date with all of our upcoming services and resources and funding opportunities. So thank you all for joining, and enjoy your afternoon.